Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
Hey listeners! Today's the fourth episode in our series on ovarian cancer. Today, we're reviewing recurrent, platinum-resistant epithelial ovarian cancer. Sydney, what are our learning objectives?
Our objectives are to define platinum-resistant ovarian cancer and explore its prognosis, discuss recommendations for systemic chemotherapy management for platinum-resistant ovarian cancer, to explore the role of bevacizumab in platinum-resistant ovarian cancer, to discuss updates to FDA approval for PARP inhibitor use in platinum-resistant ovarian cancer, and lastly, to recognize options for targeted therapies in this cancer.
Let's get started. As a reminder from our last episode, platinum-resistant disease is defined as recurrence of disease within 6 months of finishing original or most recent platinum therapy, and platinum-refractory disease indicates progression of disease while on initial or first-line treatment of platinum. In general, because of these initial poor responses, retreatment with a platinum compound is not recommended. Median progression-free survival is unfortunately low with retreatment of platinum-resistant tumors. It's quoted at around 5 to 6 months, with response rates which are usually either partial or clinically stable disease, and these range from 10 to 30%. Historically, life expectancy for these patients was about a year, but we have promising results with newer therapies resulting in patients living longer.
The NCCN guidelines do not differentiate treatment recommendations for different histologic subtypes of epithelial ovarian cancer and recurrent disease. Generally, systemic chemotherapy, clinical trials, and/or best supportive therapy or care are all options. Most of the trials for recurrent therapies are randomized phase 2 trials. Thus, the majority of the recommendations are category 2A or 2B. Regardless of the choice for retreatment therapy, reevaluation should occur after 2 to 4 cycles to determine if patients are having a benefit. Unfortunately, for patients who progress on 2 consecutive chemotherapy regimens without clinical benefit, the NCCN states that these patients may not benefit from additional therapy.
Expert consensus opinion is that combination therapy does not typically give additional benefit over single-agent treatment in the platinum-resistant recurrent setting. Toxicities tend to increase substantially with combination treatment, which are difficult to justify with lack of clinical benefit. The ideal single-agent treatment isn't known, given that response rates are pretty similar across the board, around 20%. Potential single-agent cytotoxic agents include docetaxel, oral etoposide, weekly paclitaxel, liposomal doxorubicin, and topotecan. Some of these agents can be given in combination with other agents, as we'll discuss later in this episode.
Recall from our last episode the Gordon trial. This included patients with both platinum-sensitive and platinum-resistant disease and stratified them by platinum response and bulky disease. It investigated single-agent liposomal doxorubicin versus single-agent topotecan. In the platinum-resistant group, there was no difference in progression-free survival or overall survival between the 2 agents. Stratified by bulky disease, there was also no difference.
Other agents that can potentially be beneficial in this setting include altretamine, capecitabine, pazopanib, cyclophosphamide, doxorubicin, ifosfamide, irinotecan, melphalan, oxaliplatin, pemetrexed, and vinorelbine. Hormonal therapy such as tamoxifen, aromatase inhibitors, leuprolide acetate, and megestrol are also reasonable options in patients who cannot tolerate or haven't responded to cytotoxic regimens.
Let's say I have a patient who has undergone prior combination platinum therapy and now has significant neuropathy. Are there any agents that are, quote, gentler in this case?
In that case, topotecan or gemcitabine may be a good option since they do have a better neuropathy profile. Typical side effects include alopecia, nausea and vomiting, and myelosuppression. Another lifestyle-conscious treatment is etoposide. Because it has an oral option, it can be good for patients who need breaks from infusions, who have to travel far for their treatments, who aren't very symptomatic, or who have low-level disease. What about bevacizumab?
Bevacizumab is an option as both a single agent and with other agents. In fact, it carries a 2A recommendation from NCCN for single agent therapy for both recurrent platinum-sensitive and platinum-resistant disease. The overall response rate is about 20%. It is contraindicated if the patient has a risk of a GI perforation, as this can be a fatal side effect. This has been studied in several trials. The first to discuss is GOG 170D, mentioned in our last episode. It was a phase 2 trial published in 2007 evaluating single-agent bevacizumab until disease progression or unacceptable toxicity for persistent or recurrent platinum-sensitive and platinum-resistant ovarian cancer. Enrolled patients had a maximum of 2 prior regimens. The overall response rate was 21% and progression-free survival at 6 months was 39%. 10% of patients experienced hypertension, but there were no GI perforations or fistula formations seen in the trial. Platinum sensitivity, age, and number of prior lines of therapy were not associated with response. The Canistra trial, published in 2007, was a phase 2 study evaluating single-agent bevacizumab exclusively in platinum-resistant ovarian cancer. They included 44 patients who had progressed within 3 months of discontinuing their prior therapy and had been treated with a maximum of 3 prior lines of therapy. The median progression-free survival was 4.4 months and median overall survival was 10.7 months. Notably, 11.4% of the overall enrolled patients had a GI perforation. And in the patients with 3 prior lines of chemotherapy, the GI perforation rate was 24%. This is compared to 0% in the 2 prior lines group. Taking into account GOG 170D, whose inclusion criteria had a maximum of 2 lines of prior therapy, used the same dosing schedule, and had 0% risk of perforation, these 2 studies may suggest that the risk of GI perforation may be higher in patients who are heavily pretreated.
The Aurelia trial, published in 2015, evaluated the use of bevacizumab in combination with chemotherapy in recurrent platinum-resistant ovarian cancer. Patients with greater than 2 prior lines of therapy, platinum-refractory disease, or history of bowel obstruction were excluded. Investigator choice chemo included paclitaxel, liposomal doxorubicin, or topotecan. Crossover to bevacizumab was allowed after progression through single-agent chemotherapy. The study found that adding bevacizumab improved progression-free survival from 3.4 to 6.7 months and improved the response rate from 11.8 to 27.3%. Overall survival difference was not statistically significant, but differed by a 3-month trend. The majority of the patients on study had not been treated with bevacizumab before, so it's hard to know how to extrapolate this to patients who previously have received bevacizumab. In further analysis, the study noted that the paclitaxel and bevacizumab group derived the most benefit from the addition of bevacizumab. As a result of this, some providers feel that paclitaxel and bevacizumab seem to be the most active regimen in platinum-resistant ovarian cancer. From the Aurelia trial, weekly Taxol, liposomal doxorubicin, and topotecan in combination with bevacizumab are all recommended as options by the NCCN for recurrent platinum-resistant ovarian cancer. 2 years later, an exploratory analysis of the Aurelia study was published to evaluate the effect of the high crossover rate to bevacizumab from single-agent chemotherapy. Of the 182 patients randomized to the chemotherapy alone group, 78 were given bevacizumab after progression on single-agent chemo. Compared with the patients who never received bevacizumab, patients treated in the upfront chemo and bevacizumab and patients who received bevacizumab after progression had a reduced risk of death, with a hazard ratio of 0.68 and 0.6 respectively. There were equivalent tolerance between those receiving it upfront and after progression. This exploratory analysis called into question whether the high crossover rate to bevacizumab in the Aurelia study confounded results in the intention to treat population. because when the group who ever received bevacizumab during the study, during upfront or after progression, was analyzed, the overall survival benefit was statistically significant.
Similarly to our last episode on platinum-sensitive disease, the FDA indications, or lack thereof, for PARP inhibitors have changed in recent years. At this time, PARP inhibitors are neither approved for use nor shown to be effective with platinum-resistant ovarian cancer. There have been several phase 2 studies evaluating the response in platinum-resistant disease informing this statement. In 2015, Kaufman et al. Evaluated olaparib monotherapy in patients with platinum-resistant disease with a germline BRCA1 or 2 mutation. Overall response rate was 31%. In 2016, Domchek et al. Performed a similar study with olaparib monotherapy in heavily pretreated germline BRCA1 or 2 patients with a 30% response rate and an 8-month progression-free survival. The bottom line from these two studies is that response to PARP inhibitors in platinum-resistant disease, regardless of BRCA status, is very low. In 2022, the Aerial 4 survival data was presented at ESMO Congress investigating rucaparib monotherapy versus standard of care chemotherapy in recurrent BRCA-mutated epithelial ovarian cancer. This trial included patients with both platinum-resistant and platinum-sensitive disease. When further stratified into the platinum-resistant group, a survival detriment was seen with overall survival of 14.2 months versus 22.2 months in the rucaparib monotherapy versus standard of care chemotherapy group. What about other targeted therapies?
When it comes to checkpoint inhibition and immunotherapy, the results have not been as promising in ovarian cancer as in other gynecologic disease sites such as endometrial and cervical cancer. Hamanishi et al. Published a safety and efficacy study with a small number of patients which showed some activity of nivolumab in platinum-resistant disease. The NINJA trial was a follow-up phase 3 randomized controlled trial in patients with platinum-resistant epithelial ovarian cancer published by the same author in 2021. These patients had received less than or equal to one regimen after being diagnosed with platinum-resistant disease and were randomized to nivolumab versus standard of care chemotherapy, which was either gemcitabine or liposomal doxorubicin. The overall survival was 10 months versus 12.1 months with nivolumab versus chemotherapy, and progression-free survival was 2 months versus 3.8 months. There was no difference in overall response rate between the two groups. The takeaway from the NINJA study was that nivolumab did not improve overall survival, had a worse progression-free survival, and had equivalent overall response rate compared to the standard of care group.
Keynote 100, presented as an abstract with final data in 2020, evaluated the utility of pembrolizumab in platinum-resistant ovarian cancer. It was a phase 2 study with 2 cohorts. Cohort A patients had received 1 to 3 prior lines of treatment with a platinum-free interval between 3 to 12 months. Cohort B was heavily pretreated with 4 to 6 prior lines and a progression-free interval of greater than or equal to 3 months. The primary endpoint was overall response rate, with a rate of 7.4% and a duration of response of 8.2 months in Cohort A, and a rate of 9.9% and a duration of response not reached in Cohort B. In the final data, the investigators found that overall response rate increased to 18% in Cohort B if the PD-L1 combined positive score was greater than or equal to 10. In patients with a combined positive score greater than or equal to 1, overall response rate was 7 and 10% in Cohort A and B respectively. Median overall survival was about 18 months in both cohorts. In those with combined positive score greater than 10, overall survival was 21.9 months and 24 months in cohorts A and B. 75% of patients on trial had treatment-related adverse events, 20% of which were grade 3 to 4. There were 2 treatment-related deaths due to Stevens-Johnson syndrome and hypoaldosteronism.
Another trial, Topazio Keynote 162, published in 2019, was a phase 2 trial evaluating the combination of pembrolizumab and niraparib in patients with recurrent platinum-resistant epithelial ovarian cancer. Of the 62 patients included, the overall response rate was 18%, and 5% of patients had a complete response. The duration of response was not reached. In exploratory subgroups, the overall response rate was 21% in patients with PD-L1 positivity and 10% in patients with PD-L1 negativity. HRD status, BRCA mutation, and prior bevacizumab exposure did not predict response. Those with 1 to 2 prior lines of therapy had higher response rates compared to those who were more heavily pretreated. Overall, the study suggested that niraparib in combination with pembrolizumab may have promising activity.
In 2020, NRG-GY003 was published evaluating the combination of nivolumab and ipilimumab versus nivolumab alone. To refresh your memory, ipilimumab targets CTLA-4, a checkpoint antigen on T cells that suppresses the priming phase of the immune response. In this phase 2 trial, the 100 enrolled patients had persistent or recurrent epithelial cancer. 63% of these patients had platinum-resistant disease. Overall response rate was higher in the combination group, and progression-free survival was improved, but only by 1.9 months. Overall survival was not different. The combination regimen was more toxic and had higher rates of discontinuation. In exploratory analysis, patients with poor prognostic markers, including performance status, platinum-resistant disease, older age, more prior regimens, responded more robustly to the combination regimen. Patients with clear cell histology also responded more robustly.
Interesting. So overall, checkpoint inhibitors don't sound like a home run, but probably could be considered for some of our patients with disease that's harder to treat. Luckily, there are some other novel therapies which have shown some promising activity. Namely, mirvetuximab soravtansine, or MIRV, which is a folate receptor alpha antibody and microtubule inhibitor antibody drug conjugate. In 2018, the Forward-1 trial was published comparing mirvetuximab versus investigator's choice chemotherapy in platinum-resistant epithelial ovarian cancer. The primary endpoint was progression-free survival in the intention-to-treat population and folate receptor high, meaning greater than 75% saturation populations. The PFS was not statistically different in either group, but there was an overall response rate of 24% versus 10% in the MIRV versus chemo groups. Patients with the higher folate receptor alpha expression had the best response, and there were fewer treatment-related events leading to dose reduction or discontinuation in the mirvetuximab group versus standard chemotherapy. MIRV has some unique toxicities, particularly in the eye, which we'll explore further in our biologics episode. With the results of Forward-1 in mind, MIRASOL was designed to evaluate the activity of mirvetuximab soravtansine in patients with high FR alpha expression. Patients were randomized to MIRV versus chemotherapy with either paclitaxel, liposomal doxorubicin, or topotecan. Of the 453 patients enrolled, 62% had received prior bevacizumab therapy and 55% had received a prior PARP inhibitor. Progression-free survival improved from 3.9 months in the chemo group to 5.6 months in the mirvetuximab group. Overall response rate improved from 15.9% to 42.3% in the mirvetuximab arm. 5.3% of patients in the mirvetuximab group had complete responses versus none in the chemotherapy group. Most importantly, though, overall survival improved from 12.8 months to 16.5 months in the mirvetuximab group. This study led to full FDA approval for mirvetuximab soravtansine for folate receptor positive platinum-resistant ovarian cancer for patients treated with up to 3 prior therapies.
In 2023, Gilbert et al. Published a phase 2 trial evaluating the combination of mirvetuximab plus bevacizumab in patients with platinum-resistant epithelial ovarian cancer. All of the included patients had a folate receptor alpha saturation of greater than 25%. 52% of the included patients were heavily pretreated with greater than or equal to 3 prior lines of therapy, and 59% had received prior bevacizumab. The overall response rate was 44%, and 5 of the 94 included patients had a complete response. Duration of response was 9.7 months, with a progression-free survival of 8.2 months. The Gloriosa trial is an ongoing phase 3 trial evaluating this regimen of mirvetuximab plus bevacizumab compared to bevacizumab alone. The Elucida trial is another phase 2 ongoing study evaluating a different folate receptor therapy in patients with platinum-resistant ovarian cancer.
I'm looking forward to the results of these ongoing studies.
Me too.
Our discussion wouldn't be complete without mentioning the patients who can no longer tolerate cytotoxic, immunologic, or biologic therapy. Endocrine therapy can be considered in patients who have limited or no symptoms with evidence of progression. In a Cochrane review, tamoxifen has been found to have a 10% overall response rate, and letrozole also has about a 10% response rate in recurrent ER-positive ovarian cancer. But to also round out this discussion, in these patients with recurrent platinum-resistant ovarian cancer, clinical trials are another important option. Tumor profiling is of the utmost importance to search for specific mutations which may make these patients eligible for various clinical trials or even different therapies. Specifically, Fu et al. Published a 2022 basket trial of the WEE1 inhibitor, adavosertib, in refractory solid tumors with a CCNE1 mutation. The ovarian cancer patients responded more robustly than the other disease sites, with an overall response rate of 36%, median progression-free survival of 6.3 months, and a median overall survival of 14.9 months.
A general theme of today's episode is that with increasing number of different therapies, particularly in patients with platinum-resistant cancer, disease becomes more difficult to treat. Involvement of palliative care can be beneficial, both for alleviating cancer-related symptoms and for assistance in management of end-of-life care. The majority of patients who develop a malignant bowel obstruction will have a life expectancy of less than 6 months. Palliative chemotherapy, G-tube placement, or even TPN can be topics of conversation, but this needs to be individualized to the patient.
Hospice care with the goal of patient-centered end-of-life care should not be underemphasized.
In future episodes, we'll discuss principles of palliative care and end-of-life management.
That's all we've got for today's 4th episode in ovarian cancer. Still to come, rare types of epithelial ovarian cancer, germ cell and sex cord stromal tumors, and surgical considerations for ovarian cancer. Here are takeaways from today's episode. Platinum-resistant ovarian cancer describes progression within 6 months of finishing either original or most recent platinum-based therapy. And platinum refractory disease describes those who progress while on their initial platinum-based chemotherapy. Patients with platinum-resistant or refractory disease generally have a poor prognosis, with more limited treatment options, and response rates to chemotherapy are between 10 to 30%. Options for treatment include clinical trials, recurrence therapy, or a discussion of best supportive and palliative care.
There's not a standard chemotherapeutic regimen to use in platinum-resistant ovarian cancer. Generally, single-agent therapy is preferred, and most evidence is level 2A to 2B.
The GOG 170D trial, Canistra trial, and Aurelia trials evaluated the use of bevacizumab in platinum-resistant ovarian cancer. In all trials, bevacizumab improved progression-free survival. The Aurelia trial demonstrated an additional benefit from adding Bev to chemotherapy. Based on these trials, bevacizumab as single agent or in combination with chemotherapy is an option for patients who are not at an elevated risk of GI perforation.
PARP inhibitors are not approved for use in platinum-resistant ovarian cancer, based on updated survival analyses from Ariel 4 showing a survival detriment for PARP inhibitors in the platinum-resistant setting.
Mirvetuximab soravtansine is an antibody-drug conjugate that has FDA approval for use in platinum-resistant ovarian cancers with folate receptor alpha mutation, based on results from the FORWARD-1 and MIRASOL trials. The combination of mirvetuximab and bevacizumab has been evaluated in the Gilbert study published in 2023, which demonstrated an overall response rate of 44%. This regimen is currently being evaluated in the Gloriosa trial. Other targeted agents are under investigation. As such, tumor sequencing of recurrent cancers is very important to identify possible targeted options and clinical trial enrollment.
Immune therapy and checkpoint inhibition have had mixed results in platinum-resistant ovarian cancer, with only some trials showing benefit and short benefit. Nivolumab was evaluated in the NINJA trial and did not show a benefit to this regimen compared to chemotherapy. Nivolumab and ipilimumab were evaluated in NRG GY003 and improved PFS by about 2 months in platinum-resistant ovarian cancer. Pembrolizumab and niraparib were evaluated in the Topazio Keynote 162 studies and showed activity. Ongoing trials are evaluating the use of immunotherapy in platinum-resistant ovarian cancer.
This has been another episode of Ready, Set, GYO, your source for all things gynonc.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross.
Our sound editor is Brogan Brown.
Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Ryan Spencer, faculty at the University of Wisconsin, who reviewed the content of this episode for accuracy and completeness. Sydney and Maya signing off.